I thought I had stopped the recording, but apparently it's still recording. Okay, welcome back. We're going to talk about defense mechanisms. Does anyone have any idea or have any insight as to what defense mechanisms are? Disassociation, well, I guess if you want to, I guess we could use it in a sense of, well, tell me how you use disassociation, Samantha. We all use them. We use them a lot. They can be negative, they can be positive. Yes, getting angry, blaming others. You fail an exam. Right away, you said, it's not my fault, so we can't teach. That's an example of a defense mechanism. And as we go through them, we will get to learn them. For some reason, they tend to be a little bit, every semester when I teach them, a lot of people tend to mix them up, so they can be a little bit challenging to remember, so we'll go over them quite a bit as we move forward in the course. It's a very important concept of coping. Everyone uses them to manage life conflicts, to avoid anxiety, or to deal with stress. As a mental health worker, it's important to know your own defense mechanisms as well as learn to recognize those of your patients. Transference. Transference is the client's feelings towards the nurse and their relationship. So this is the patient having feelings or emotions that they channel towards the nurse. And by default, and conversely, countertransference would be the nurse's feelings towards the patient. Like, have you ever met somebody and it could be you working in a nursing home or clinical caring for this little old lady, and you just have this warm feeling towards her, you just want to care for her, you want to take care of her, because she somehow kind of reminds you of your grandmother or old aunt that you like or something. Has anyone ever experienced that caring for anybody? Yes. So that would be your countertransference. Or it could be, have you ever met somebody like it's the first thing you meet them and just something just doesn't click. You just don't care for this person quite much. And when you think about it, it kind of reminds you of that girl from high school you didn't quite like. That's your countertransference. And just yes. And just like how you have those feelings towards your patients, likewise your patients will have those feelings towards you. Like I have those experiences with especially my older African American and my older Hispanic patients. Well, older women. They're like, oh, get over here, Zoe. I'm not shaking your hand, and they want to hug me because they see me as a daughter. And even though I try to extend my arm first, no, they're going to grab me because they're seeing me more like in the light of a daughter. So they're transferring those feelings onto me. So it's important to recognize yours as well as those of your patients. It's usually a problem when they're not recognized and they can negatively impact the therapeutic relationship when they're not noticed. So displacement. This is channeling your feelings or thoughts from its actual source to someone or something else. Like when you get mad at your sister, so you break the drinking glass by throwing it against the wall. So those feelings that you just put into the glass and throw it into the wall were actually feelings for your sister. So you're displacing those feelings. There is also intellectualization. And this is when you seek to overuse abstract thinking, like you try to explain everything using either technical jargons or medical terms to explain what's going on. There is undoing. This is when someone tries to reverse or undo a thought or feeling by performing an action that signifies an opposite feeling from the original thought or feeling. You'll be like, what? So, for instance, if you have feelings of dislike for someone, you buy them a gift. So you're trying to undo your feelings by acting in an opposite way. There is compensation. What do you think compensation is? Anyone, someone.
You make up for something by doing something else?
Yeah, like how often have you heard like someone talk about like someone that's short? They're like, oh, because he's short, his attitude is big, or because he's short, he drives this really big car. Because you know what I mean? They're trying to say he's compensated for something.
Napoleon complex?
Yes. Counterbalance of deficiencies in one area by excelling in another. Then we have identification. This is when you seek to act like, emulate somebody else, and that could be a defense mechanism as well. So they're not showing their true feelings, they're using the image or the behaviors of someone else. Sublimation. This is redirecting unacceptable instinctual drives into personal and socially acceptable channels. So this person could have intense rage and they redirect it in the form of participating in sports or boxing. So like I could be, like I get really, really angry, so I join a fight club where I can really work out those feelings in an acceptable way. Sublimation. There could also be regression. Anyone want to take on regression? Reverting to an earlier stage of development. Like your boss calls you in the office to talk about your performance review, and you're in there kicking and screaming like, how old are you? That's regression. Thank you, Julie. Then we have suppression. This is an effort to hide or control unacceptable thoughts or feelings. So say you're attracted to someone, but you say you really don't like the person at all. You're suppressing those feelings because that's not how you truly feel. I will ask Pam to post the handout on defense mechanisms because you need to know your defense mechanisms. Very important in caring for patients. So we go into discussing different mental health practice settings. The acute care setting. This is for the patient who probably got sent to the hospital because they were suicidal, homicidal. This patient is often a danger to themselves or to others. They're usually unable to meet their basic needs. And one of those basic needs be?
Feeding, bathing, dressing, eating.
Yes. There's a dangerous decline in mental status. They're not reasoning well. They're not thinking well. These patients have a lot going on cognitively as well. They have a medical or a mental health need. So you'll find these patients in the acute care setting. This mental health patients can also be in the community health setting, where the nurse could be used in primary, secondary, and tertiary preventions. I work in a community health center, and that's how we meet the patient's needs in the outpatient care setting. It could be a partial hospitalization program. So sometimes when patients say they're in the acute care setting and they get discharged home, you can't. It's not good practice to have the patient where they have all these supports in place and then say, "Oh, no, you can go home." So they step them down to a partial hospitalization program where they come in maybe 2, 3, 4 times a week for therapy, med management services, a check-in. So it's partial hospitalization. Sometimes patients with mental health care needs in the community, they have an assertive treatment team. It's an ACT team. So this is a team of individuals who work very closely with the mental health patients in the community setting. So they will go over, help them to organize their homes, help them to go grocery shopping, help them to supervise cooking, take them to appointments, get them engaged in services out in the community. Because without this assertive team involvement, this patient most likely will not engage in activities outside of their home, nor will they meet their basic needs most of the times. I mentioned we have community health centers. There are rehab programs, or it could be home care. So, having mentioned all these different practice settings, pretty much wherever you plan to work, you will most likely come across patients with mental health settings. It is almost inevitable not to come in contact with a patient who has a mental health disorder. So how do we treat mental health disorders? A lot of people will probably think medications and therapy, meds and talk therapy, yes. And it's important to know that they are both important. And like I try to tell patients all the time, because everybody thinks I need meds, and more meds, is that the med is, in my opinion, the smaller part of treatment. Very often patients need to engage in therapy, especially as it relates to your depression, your anxiety, those kind of symptoms. They need to be able to engage with someone. And I'm sorry, guys. I'm sure you're hearing the blower outside my door because they're blowing all the stuff from the roof. Can you hear me still? Okay, great. So I try to explain to them that therapy is of most importance because they need to engage effectively in their treatment, because no matter how much you take medications for a symptom, unless you deal with the stressor or deal with the root of the problem, that problem will always be there. This is why therapy is important. As mentioned here, according to Freud, it will assess unconscious thoughts and feelings, because sometimes you're feeling depressed and sometimes patients are not even able to reason through their thoughts and feelings to say, this is why I'm feeling depressed or this is why I'm feeling anxious. So by going to therapy and reasoning through what's going on, they get a better insight as into what's going on, and in doing so, more often than not, they can also work to alleviate the issue. Therapy is usually lengthy, and this is why a lot of patients don't want to do therapy. Not lengthy in its individual session, but usually goes on for several months, sometimes even years. It just depends on the unrelenting nature of the issue. It seeks to resolve internal conflicts. Maybe it's an issue you had in childhood that you never quite resolved with your mother. Mother has passed and you're still dealing with this issue. It usually focuses on past relationships that could have skewed your perception of yourself, your perception of others. So it tends to go back and find the root of the issues. Therapists use different tools or associations. They could sometimes even analyze your dreams just to see what is going on that you're not consciously recognizing. So these are what we call non-pharmacological. Pharmacological medication, non-pharmacological. These are treatments that are used that are not medication-based. So psychotherapy is a lot of talking. Usually therapist to client, you sit and you talk through these issues. Very often patients will meet with their therapist, depends on the acuity level. It could be weekly, but more often than not, the schedules are very often like bi-weekly. It depends on the acuity. Sometimes you're telling me twice weekly. Is it someone who is acutely depressed, acutely suicidal? It could be twice weekly as well. Usually focuses on the patients, usually addresses specific problems, whether it be interpersonal, or is it their communication? Are they in a state of bereavement? It looks at their roles and their relationships as well, their thoughts, their behaviors. Any questions so far? So talk therapy is one. There's also behavioral therapy. It can be used to treat depression, anxiety, phobias, addictions. So very often, especially my younger patients, well, all patients I recommend therapy, but sometimes I will have children come to me and the parents are like, oh, little Johnny is doing this and I can't handle this. I need to get him on something. And I'll be like, okay, is little Johnny in therapy? And sometimes mom or dad will say, yes, he's been in therapy for the past year and there has been no improvement. So his therapist thought it's time we added medications on to address his symptoms. Appropriate. Sometimes there'll be little Johnny who mom will say, oh no, he's therapy. No, he's not going to sit and talk to anybody. He just meds. And I'd be like, no, my number one recommendation is therapy. Because when I start giving little Johnny meds at age 6, will little Johnny ever learn to resolve his issues and work through what's going on in his head? I don't think so. And very often I'll make it a requirement for treatment that I will not prescribe unless little Johnny is engaged in therapy. Because meds and therapy work best to address the symptoms. But therapy is definitely a major and important component of any patient's treatment. Another form of therapy that is very widely used is cognitive behavioral therapy. Is anyone familiar with any kinds of these therapies? There's cognitive behavioral, there's the DBT, dialectic behavior therapy. Anyone familiar? What are your experiences with them? Yes, you look at your feelings, your behaviors. Like cognitive behavioral, you have a patient that's skills-based, certainly. Say, let's look at CBT. You have your teenage patient who's cutting, which is a very common issue these days. And while that patient is cutting because they're feeling depressed or they're feeling, for lack of a better term, as they explain it sometimes, blah, and it makes them feel, would any kind of medication ever effectively address the cutting behaviors? No. So you refer this patient to cognitive behavioral. Let's see what thoughts you're having that transfers into cutting. Let's examine your thoughts and your actions. Dialectic behavioral therapy is used very often for patients who are suicidal. It's used very often for patients with a borderline personality. It's used for a lot of different things because it's skill-based and they go through a whole list of stuff like meaningful activities, like finding different things to focus on. So it helps patients, it gives them the tools to work through their thoughts and feelings, and then the medication is just added on for support. And someone used for addiction recovery supports, yes, it helps them to walk through the different steps of recovery. Instead of just saying, give me some pills because I'm anxious and depressed and I'll just stop them for the rest of my life. Absolutely not. When you have those skills, they are yours. You can employ them and use them. There is individual therapy. And it teaches coping skills, most importantly. So when a patient comes to me and they tell me, oh, I'm so anxious, oh, I'm so depressed. And I'd be like, so what coping skills do you use? What are those? I'm like, this patient needs to go to therapy. What are coping skills, guys? Does anyone know what coping skills are?
It's easier for me to talk, so I'm just going to talk. Like learning what your triggers are and learning how to handle the way that you react to those triggers.
Yes. Or finding a way to handle your feelings. If you can recognize when you're getting anxious and it's carrying type, say I'm using deep breathing. Okay, can feel the anxiety coming on. So this is when I start deep breathing, and you start deep breathing. That's your way of coping with the anxiety, and hopefully it brings you back to baseline, and that's an effective coping mechanism. It could be meditation, it could be listening to music, it could be alcohol, it could be drugs. So coping mechanisms can be positive and they can be negative. And that's why it's good to tease these out of these patients. Like, how do you handle your depression? How do you handle, oh, I smoke a blunt, I go outside and I get something and I drink, or I count, I meditate, I breathe, I take a cold shower, I journal. So it's whatever the patient, it is whatever that works for them. So you want to find out what it is. And if it's negative, you want to refer them to therapy, because therapy is going to help them to hone on those positive ones. So therapy could be individual, where the patient is the focus, they're motivated, they engage. It could be group, where these individuals share a common interest, such as like in addiction recovery, AA meetings, in IOP. Very often they'll have like a lot of patients who are in substance recovery in one group, patients who have an anxious disorder in one, patients who are depressed in one, women's group, men's group. So these groups tend to serve different purposes. Sometimes the patients benefit from realizing that they are not the only ones who are experiencing these symptoms. Sometimes they hear the coping skills of others and they learn from others and they start using them. So a group can be beneficial to healing or working through what's going on. Some patients will tell you, I can't do group. I can't listen to their sad stories of everybody else. It just makes me feel worse. So it just depends on the patient. Groups they work to teach social norms. Sometimes they'll form friendships, and in doing so, they will form a support system. Sometimes they'll have a person in the group where they can reach out to and talk to them outside a group. Hey, I'm not feeling too well today. That person they're calling is a part of their group. They can say, how about we use the coping skills we learned last group? So it can work as a support system, friendship, for education. So group it definitely has its benefits, but I can tell you there are a lot of people who will say, I can't do group. Because a lot of people are not open to opening up about their feelings or what they're experiencing in the presence of others as well, as it relates to a group setting. This is why groups, they have their rules. Whatever happens in group stays in group. You can't discuss what anyone divulges in group. So it's a close-knit setting where you have rules that govern what is done and said, and it is the hope that it is respected. Yes, like in AA or NA, those are also groups as well. There could be self-help, teaching, education, supportive, or therapeutic. So lots of different types. It could be therapy that's not individual. What if it's an adolescent who's having problems with mom and dad? As well as meeting the patient one-on-one, the therapist also wants to meet with mom and dad at some point. So how about we bring mom and dad in, and you can share with them how you're feeling, and then mom and dad can have a forum to share how they're feeling, and the therapist will function like as the moderator between the two. So therapy, non-pharmacological form of treatment, is very important to a patient's care. So that's therapy. Now we're going to look at brain stimulation therapies, ECT. And if you've watched any movie that shows ECT, it depicts it in the worst way, like you're frying someone's brain, right? And I can tell you, I've had patients who tell me, oh, never again, I've not been the same since. And then I'll have patients who tell me, oh, since I did ECT, I've been a lot better. So usually this is recommended for the patient with a major depressive disorder, schizophrenia, who has mania. And it's usually not the first line treatment. So a patient doesn't walk into your treatment facility and they're majorly depressed, and the first treatment recommended is, let's send them off to ECT. No, this is probably after years of trying several other methods, medication, therapies, different treatment modalities, and working. Because I can tell you, I have patients right now that I've known them for the past 2 years, and every single visit, I'm so depressed. Oh, I'll never get better. That's just who I am. I'm just depressed. So maybe this is a suitable candidate for ECT. Some patients who will not engage in it because it has a stigma attached to it. It is very important, and you should know that you need to get informed consent for patients prior to this procedure. It's like, duh, I'm not just going to send you off to do this without talking to you about it, explaining it, make sure you sign off, but I'm just making sure you know that you need to know that you need an informed consent for patients prior to this procedure. The main side effects: confusion, lightheadedness. There could be even short-term memory problems. There could be TMS, also used for depression not responding to medication. Again, you have this patient who's been taking 4, 5, 10 different antidepressants throughout their life. Nothing works. They're doing therapy. Nothing works. So maybe this is the patient who we need to refer to an alternative therapy, such as transcranial magnetic stimulation. It is non-invasive and it works according to some patients. Or maybe these patients need the vagus nerve stimulation. This is also for major depressive disorders resistant to ECT. So they did the ECT, didn't work, so let's refer them to the VNS. So there are lots of different treatment recommendations. So medication isn't the start-all, medication isn't the end-all. It is one of the treatment modalities for a patient with a mental illness. Any questions? Okay. Stress management. So some stress provides interest and purpose to life. Too much stress can cause distress, anxiety, or anger. And some level of stress, sometimes it works in a positive light where it can propel you to be more keen or give more interest. But it's all about how your body responds to this increased stressor. Your ability to manage your stress effectively. And your ability to respond and cope in an appropriate manner. Now, you're in nursing school. I know you know what stress is. I've been there. The exams coming up. You have to study for this. You're looking at the boards in the future. You're wondering about your job. You're still working. You have a family at home. The stress is real. And some people will say, that's why I can't go to nursing school, because I can't handle that stress. So that person has learned to manage their stress. They stay away from the stressor. Or is it someone who's going to engage in nursing school and start falling apart because they don't possess the skills to work through and cope effectively through the stressors. If you have an exam coming up, does that bring on stress? Well, for the majority, I know it does. So how do you cope with that stress? I'm listening. Any coping mechanism you use to cope with like the stress brought on by nursing school, exams? How do you cope with this? Talk to friends. Use a focus. You say you focus and you.
I have a stick that has incense that you inhale,
Yes.
and it's called a focus stick. You inhale it. It's like a mini inhaler, but it has like eucalyptus and different lavender, different things to help you calm.
Oh, so scents. That's
Yeah.
one mechanism. When
A
I
huge
was,
scent person.
I'm sorry?
A huge scent person. I love scents.
Scents. So it works for you. When I was in nursing school, for every exam, I would just sit there and I would deep breathe and I would pray. And then when I was done with that, I was ready to go. That's what worked for me. Also, I made sure I paced myself because I know I could not attempt to write a paper the night before it was due. While I had friends who would say, "Oh no, Zoe, I don't know how you write it like a week before." I'd be like, because I can't the night before. I can't function under stress. I have to pace myself. And some people are like, "Oh, I work awesome under stress. That's when I'm at my best." Some people eat a glass of wine. And remember, remember, coping mechanisms can be healthy, they can be unhealthy. So you have to be able to manage your stress. And your ability to manage or not manage your stress can be the difference of being afflicted with a mental health disorder or working through a stressor and going on with life. So your response will vary. It can depend on your age. When I was 6, 10, 12, I had a stressor, I probably cried. Because that's how I coped with it, or that's how I dealt with my stressor then. So age played a factor as I matured over time and got older. I realized that crying really didn't help me to work through my problems, so I had to find new ways to cope. It could be gender. Someone mentioned that they talk to friends. While I'm sure a lot of male will tell me they're not talking to anybody, they're going to work this out themselves because they're a macho and they can work this out. It could be culture. Is it okay in your culture to share that you have a stressor? Is it okay in your culture that you're going through a divorce? So it could be cultural. It could be life experiences. I have done several tests at this point in my life. I have done the nursing boards 3 times. So I kind of know what to expect. I did my LPN boards, I did my RN boards, I did my NP boards. So there's not quite much of a stress anymore. I just prepare myself for it. While years ago when I did my LPN boards, I was like shaking at the knees. So it could be life experience. Or it could just be lifestyle where I live a calm lifestyle and I work through my issues differently. So your ability to manage your response and your ability to manage stress is very, very important. And this is why I ask patients, can you tell me your coping skills? Because if they lack coping skills, then that's a red flag. The stressor will increase and they will probably start falling apart. So in looking at a patient's stress level, you want to assess their protective factors. So protective factors are those factors in your patient's life that they're going to tell you, these are things that are important to them. These are things that when they look at their life and think about living, these are the things that, like, my protective factors are my children. I live for my children. Everything I do is for my children. Or it could be that it's for my job. Or it could be the patient tells you, nothing. I have nothing in my life worth living for. So those are red flags as well. Their physical health. Are they afflicted with some chronic health disease? Which could play heavily into their ability to work through their stress? Is it something that there is no cure for? Do they have a strong sense of self? I know who I am, and I can get through anything if I put my mind to it. Or, I've never quite succeeded with anything in life. It's going to be hard for me to achieve much. What is their sense of self? Again, does religion play a role in what's going on? How optimistic is this patient? Can they see the light of the end of the tunnel, or is this the end of their world in their eyes? How interested, how vested are they in their care? Look at their interpersonal relationships. Do they have good relationships around them? Do they have a good support system? So stress management is very, very important. So stress, there's acute stress, fight or flight. There's some sense of apprehension. There's some unhappiness. Not quite hungry now, all of a sudden your stomach feels real. It could be sweating, increased heart rate, increased blood pressure. Before every exam, I get diarrhea. That's how my acute stress works. I know my body, that's what happens. Before every exam, I get a cold because my immune system is suddenly depressed. So that's the acute stress factor. It could be prolonged stress. It could be the patient that tells you they are chronically anxious. They have panic attacks that's been going on for years. They have issues with sleep. They're depressed. They have chronic pain. This is the patient that has been losing weight or has been gaining weight because the stressor has been going on, which increases their risk of a stroke, a heart attack, or poorly controlling their diabetes. This is the patient who could have an increased blood pressure, decreased concentration, they're irritable, and this is the prolonged stress. Like if someone's in an abusive relationship, that could be a prolonged stressor. It could be just an exam I have next week. That's an acute stressor. And those are the different responses. Treatment, cognitive reframing. You want to examine and restructure this patient's irrational thoughts. And this is done through cognitive reframing is done through
Behavioral therapy?
yes, cognitive behavioral therapy. Patient needs to learn relaxation techniques. This is coping skill guided imagery, breathing exercise, and muscle relaxation, physical exercise, journaling, mindfulness, whatever works. But this is how you learn to manage your stress. So you don't want a patient freaking out, hyperventilating, getting into panic attacks. You teach them ways to de-stress in a healthy manner. So that is stress. So some important concepts. Therapeutic communication, we already looked at that. It's a thoughtful sending, receiving of information. It's not just simple conversations. There's a lot to pay attention to. Eye contact, body language, your stance, your tone. So therapeutic communication is, as it says, not just having a conversation. You need to be mindful of a lot of things as you engage with patients. In your therapeutic relationships with your patients, make sure you're focusing on the client's needs. Make sure you're setting goals. Make sure whatever you're employing is theory-based, tried and true empirical methods. Make sure it's objective, and also make sure you're open to supervision, which means you can talk about your feelings with whether it be your supervisor or a peer, about how you feel about this patient, about how the patient makes you feel, to see if there's any transference, countertransference, if there's anything going on there that's impeding your ability to care for this patient effectively. Any questions? Nursing interventions. It should be your goal to establish therapeutic relationships. As I mentioned, be self-aware as it relates to the issues with transference and countertransference. Identify patients' behaviors, and that's where it plays into identifying like their defense mechanisms that are being used. Is the patient in denial? Are they repressing their feelings? It's good to be aware of what is going on and when it's going on. Safety, I don't have to tell you this, you know this, is always paramount, is always at the top of the list. Modify, so therefore you need to modify the environment as needed. This is not the patient you're going to walk in their room, they're depressed, suicidal, you're going to do a dressing change and leave the scissors on their bed. That's pretty much giving the patient a weapon. You want to give the medications as prescribed and watch for the effects. So if you give an anxiolytic, the patient is having a panic attack, you give them something for anxiety. You want to observe to make sure it works so you can in turn report to the prescriber. I gave little Johnny the hydroxyzine that you prescribed, but it didn't work, or it calmed him down. I know this 10 minutes after he was sitting coloring. So you want to make sure you're looking out for effects as well. Engage the patients in activities that as tolerated. So not because the unit has a schedule means the patient has to follow it. What if the patient is not in the correct frame of mind at this time where they can engage in that activity? You want to make sure you're making concessions for your patients and treating your patients as individuals, not as another patient on the floor. Most importantly, avoid confrontation. You'll be like, I wouldn't be arguing with a patient. Wait until you get into the world of work and you encounter a psychiatric patient. They can pull you out and draw you in. Make sure you're being professional, avoiding confrontation. Be respectful. Like I say, this is the patient that's going to call you every name in the book. You can't lose yourself. You can't lose sight of what your purpose is in this relationship. Confidentiality is key. So you know little Johnny is on the floor and little Johnny is friends with your daughter. You can't go home and say, you know who I saw on the floor today? He's depressed and he's trying to hang himself. Absolutely not. Confidentiality is key. I can tell you how many times I've been in public and I encounter my patients. And unless they acknowledge me, as in if they wave, then I'll wave back. I do not acknowledge them. Someone alluded to HIPAA before. I'm sure HIPAA has been drummed in since you started nursing school. Remember HIPAA? Abide to HIPAA rules. Patient confidentiality, their names, identifying data. Don't leave stuff out on the tables. Don't walk away from your computer leaving a patient's charts open. Be aware of those things. Understand your federal and state laws in wherever you work. Share clients' information only on a need-to-know basis. So not because you found out some juicy information about any patient means you should share it with someone who is not directly involved in their care or has a need to know. Don't discuss patients in public areas, lobbies, elevators. Remember, you need patients' consent to share information with others. Like sometimes I'll have girlfriends, wives, husband calling and they want to talk about a patient and I cannot share any information. I can confirm that I'm treating because I don't have written consent to share any information with this person who is seeking the information. Even when I have appointments with my adolescents, and it takes a lot of parents off, and I say, well, little Johnny, so this is how this appointment goes. You can choose to have mom stay, or you can choose to have mom leave, or dad, or whoever it is. And you'll see the adult's face like, what? But I have to respect my patient, and I have to let them be autonomous, because sometimes what the child, or even an adult, what they will divulge to you by themselves, what they will divulge to you by themselves, they will not necessarily divulge when they're in the presence of another. And this is why it's very important that you don't leave it up to the patient, or the patient is not going to say, I want my mom to leave the room. or I don't want my parents here. So I always pose the question. So it's your choice. Do you want mom here? We can bring mom in after, or we can bring dad back in the end. Or would you like to talk to me by yourself? And very often they would like to talk by themselves, because very often they don't want their parents or their significant others to be privy to their deepest, darkest thoughts. Again, it makes mention of being mindful of the patient's civil rights. Your interventions should help the patients recognize and explore their thoughts, feelings. It should help to guide them towards insights about what happened prior to this present thought or feeling. So hopefully they can avoid it in the future or learn ways to cope when it happens. You can teach and validate positive coping skills and behaviors. Help them identify support systems, because they're going to be like, ask, what's your support system? Who can you reach out to? And they'll be like, I don't have anyone, I'm alone. Wait, aren't you in therapy? You have a therapist. You said you live with your mother. Have you tried talking to mom? Have you tried your school counselor? Do you have a best friend? So you can help them to identify people who are in their circle who they can reach out to. Monitor their physical needs, because it depends on their psychotic state or their mental state. That patient will ignore those needs. Not eating, not drinking. So you want to make sure you're being mindful of not just their mental, but also their physical health needs. You want to educate the patient and their family about their mental health conditions. Is it something chronic? Is it something that's brief and short-lived? Will they need to take this medication possibly for a very long time? Is this medication only going to be taken in the acute setting? So you want to make sure you're educating them so they know. Does this medication need to be taken with food? You want to give available resources, suicide hotline, food pantry, whatever the need may be. Get to know your patients, talk to them so you can provide the resources. And as I mentioned before, active listening and respect is paramount in caring for any patient, and it's no less than caring for a mental health patient. You work as a member of a team. These patients will have lots and varied needs. They will probably prescribe her for psych meds. They'll probably need the social worker. They will need a doctor. So there are lots of different providers involved with their care. Make sure you know that you're only a part of that team and choose to function within the team setting. I can't tell you how frustrating it is sometimes when my patients have left the hospital and no one even called to say little Johnny was inpatient. And while little Johnny was here, we made these med changes, because little Johnny can come back to see me and never mention that he was in the hospital last week and all his meds were changed. This is why continuity of care or working as a part of a team is very important. Respect validates patients' feelings as well as their strengths. The diagnosis is with the patient first. Not every patient who is majorly depressed is going to present in the same way. So get to know your patients as individuals, not as the schizophrenic down the hall or Mr. Bipolar over there. Get to know your patients. Patients are first. Keep your sense of humor and balance. So when that patient's hurl at things across the room at you, try to find the lighter side of it and realize it is their mental illness, or however you want to reason through it. Get supervision for questions and problems, and to validate your own feelings as well as your patient progress. Any questions? Did you guys fall asleep out there? Oh, I'm about to say, wait, are they there? So I totally enjoy teaching this. I like psychiatry, I like mental health, and I try to make it light, I try to make it fun. It's a lot of content, but we will get through it together. So if you have no questions, no concerns, nothing else you want to discuss, I will see you on Wednesday. Yes, I see both adult and kids. You're welcome. Good night, guys. Take care.